I'm Andrea with Parkinson and Movement Disorder Alliance. I'll be facilitating today and so excited to have you join our talk. Your brain's future is not fixed. How exciting and hopeful is that? We are recording today's session, so you'll be able to access that on our website or our YouTube in a day or two. So for your time today, sit back, take it all in, apply it to your own life, and know you can always access the recording later or share it with a friend or a family member. And let's see, I have Kelly here on tech support. So if anything goes wonky and you can't see and you can't hear and yesterday someone started hearing background music, send us a chat message and Kelly will do a private message to you and do some troubleshooting. And you could even sneak in, can you fix my iPhone? And who knows what her troubleshooting can extend to. Yes. Okay. I think that's all my announcements. I'll start by introducing you to Dr. Joanne Hamilton. She is a clinical neuropsychologist and she's the director of adult services at Advanced Neurobehavioral Health of Southern California. And yeah, Southern California is so big. I don't know exactly where that is, but
San Diego.
welcome, San Diego. Oh, a terrible place to live with terrible weather. Well, welcome, Dr. Hamilton. Thank you so much for being here. And can we start by, I don't know, getting to know you? Just one personal question. How did you decide to become a neuropsychologist? That's usually not something like a 5-year-old says, I want to be this when I grow up, but maybe you did.
Well, actually, so for whatever reason, I was always interested in the brain and how the brain works, even as a little person. I had no idea what that meant for a career, but that was interesting to me. And then when I was about, I think 13-ish, my very, very dear uncle developed what we now know to be Alzheimer's disease. But I'm so old that that was not really something that people knew well about. That would have been early mid 80s, and Alzheimer's disease research was just starting to come about. We were still thinking about that type of cognitive decline as a normal part of aging. And, 30 years later, we know that not to be the case, that Alzheimer's disease and Parkinson's disease and all those conditions that cause some neurodegeneration are not typical set consequences of aging, at least not the same way that a wrinkle would be. And so as I went into college, I got into neuroscience, and at kind of the ground level, when we were beginning to understand how the brain truly controls behavior. And and from there was one step after one step after one step. And I would have to guess that I had no idea what I was getting into until about 5 years ago. Maybe not that bad, but it was just the next step and the next step and the next step. And here I am. I'm a clinical neuropsychologist.
Well, welcome. We're glad you're here. And I want to tell you a little bit about our audience. So PMD Alliance has created a cohort of people at risk for Parkinson's, maybe with prodromal symptoms. We also maintain tons of programs and resources for people and their families living with Parkinson's disease. So we have a mixed crowd here today, maybe some people who have a family member or some prodromal symptoms, as well as some people who have Parkinson's. A diverse crowd, and I welcome everyone, no matter where in the journey you are. I can guarantee we all have brains, and that's why it's so good to hear from Dr. Hamilton about how we can take care of them and what we can do. So. I will hand you the floor, and I think you have some slides to start with, right?
Yes, I do. So I will just I thought I'm going to go ahead and share my screen now with everyone, because I think what we might do is just start out getting us all on the same page. And then we'll kind of take it from there. Of course, now that I say that, where is it? There it is. Um, all right. Have to get through all the it's okay, it's okay, it's okay parts.
Yes,
There we go.
every second feels so long when you're doing this, but the slides are up, they look great.
Fantastic. So what we'll talk about today are some of the behavioral modifications that individuals right now can begin to make to reduce their risk for significant cognitive decline. Because like I said, we've now learned that these neurodegenerative conditions are not just set in stone. And you might have some degree of genetic susceptibility, but for most of us, the vast majority, 85% plus, that genetic susceptibility is very inconsequential versus what we do with our bodies in our young ages, middle ages, and even older ages. So I think what's probably best is for me to explain what a neuropsychologist is. I work a lot with educates with educating folks who are experiencing or could experience a neurodegenerative condition, which, by the way, is the vast majority of us. And most people say, well, I don't even know what a neuropsychologist is. So a neuropsychologist is a subspecialist in the field of clinical neuropsychology who has had extensive education in the way in which the brain affects behavior. The brain affects behavior. And that seems so obvious. Of course, the brain affects behavior, but our job is to really understand how different parts of the brain, how different chemical systems, how different stressors and medical diseases impact the functioning of the brain, and then how that plays forward in your emotional functioning, your cognitive functioning, and your ability to just manage your day-to-day activities. So most of us who are board certified neuropsychologists have had at least 2 years of advanced training in generally neurology. We tend to run in circles that deal with more neurology, so Parkinson's, Alzheimer's, multiple sclerosis, head injury, those types of things. But we're also clinical psychologists, so we can bridge depression and anxiety and visual hallucinations and how we manage those as well. And for the most part, our job is to try to help our medical colleagues come up with treatment plans that will incorporate both the medical and the psychological. And one thing that has been helpful for my patients, when we're done with this talk, most people will say, how do I find one of you? Because not even a lot of medical providers know what we do. Unless you're in a specialty clinic like myself, a movement disorders clinic, not all neurologists understand what neuropsychology is. Not all primary care will understand us. So they don't know how to help their patients visit with one of us. And we're unique in the medical world. We don't have to have 15-minute appointments where you try to spit out everything that's happened to you in the last 30 years for some doctor to then say, I don't know, so I'm going to send you off to the next subspecialist. We actually get to visit with you for hours. And at the end of those hours, we typically have a pretty good sense of what your challenges are and where we need to at least start with those challenges. So I'm going to show you the codes, and I would recommend that everyone take a screenshot of this. And it explains exactly how you pursue a neuropsychological evaluation with your medical provider. Then we're going to identify the behavioral changes that could delay the onsets of Parkinson's disease. We now know that the genetic risk of Parkinson's is probably smaller than in any other neurological condition. It's our environment, it's what we're doing with our bodies that actually increases your risk for Parkinson's. And there's been some pretty good data recently coming out with dietary changes that can be made that will prolong the onset. And then we'll talk a lot about these changes that can be used in general to help prevent brain disease and promote healthy aging. So Parkinson's is my love. And the reason for that is when I started in this field, I was an academic neuropsychologist, so I did research. I was at the University of California, San Diego Alzheimer's Disease Research Center for most of my career, most of my early career, studying Parkinson's, studying dementia with Lewy bodies, studying Alzheimer's disease. And time again, what I was recognizing is that the people I was working with were certainly bothered by their motor symptoms. And that's the basis of the diagnosis of Parkinson's, right? The tremor, the rigidity, the slowness in thinking, the postural instability. They were bothered by that. And medication did a decent job of supporting those challenges. It was all this stuff below the surface that actually was disabling my patients and was causing problems in their relationships, problems at work, problems with the way they felt. But no one was really understanding that these symptoms down here below the surface were all part of Parkinson's disease. And so many of my patients early on were going to urology, they were going to orthopedics, they were going to you name how many different you name how many different subspecialists to try to understand why they were experiencing all these different challenges. And there was not a single like place where someone was saying, well, you have Parkinson's, or it looks like it's going to be Parkinson's, and all of these things are tied in together. And we still have a paucity. There's very few true movement disorder centers where you have all of us under one roof. That's becoming more and more available, and it's becoming more and more available through organizations like this, PMD, through Davis Phinney, through the Michael J. Fox Association. They're starting to now get the word out to primary care and to general neurology that if you have a person coming in with severe constipation, we need to start thinking about that, because we know that many of these prodromal these non-motor challenges are actually the prodromal symptom of Parkinson's. We can start to see constipation and sleep disorder and anxiety and depression 15 years before somebody actually starts to develop these motor symptoms, the tremor and the rigidity. And it's during that period of time that we can start to help patients and their loved ones know that now we're gonna attack these behavioral modifications like a warrior. This is now going to become medicine, not just fun, right? So here are your codes for a neuropsych eval. A neuropsych eval means that generally how it works is you would come in and you would meet with one of us, and we would do a very in-depth history. We would understand your upbringing, your environmental susceptibility, your stressors, your educational history. We would understand your social history. We would go deep dive into your medical history. What were you exposed to? Have you had was your job a diesel mechanic? Was your job in the agriculture industry? Were you a dry cleaner? How much toxins have you been exposed to in your life? We'll talk about that. We'll talk about your current symptoms. And then we put you through a battery of tests, could be as short as an hour, as long as 2 or 3, that tests your memory, your language, your thinking speed, your attention, all the things that go into thought. We'll ask you a zillion questions about your emotional functioning. And then we compare your performance against people who are your age and who have your level of education. And we understand where your strengths and weaknesses are. And then we help your medical providers put that together in a plan. Would you benefit from speech therapy? Would you benefit from big or loud, specific treatments to help you speak louder or to help you move with more strength? We would talk about whether you're a fall risk, whether you have REM behavior disorder that needs to be managed by sleep, or whether you're starting to have visual hallucinations that are going to need potentially medication management to prevent them from becoming disruptive or scary for you. And all of those things kind of go together. A couple things. Sometimes sometimes folks in their prodromal stage will want a baseline. And that is indeed what you want. You want something for against which we can compare your change over time. But we can't say that in we can't say that in a referral because um, against better wisdom, our healthcare system is still not set up to be preventative truly. And so baseline evals are not considered medically necessary. Instead, we want a referral that says that we're investigating non-motor changes to improve medical compliance. And then generally all insurances will cover. These codes that I have, these are actually the codes that an insurance company will use to pay your neuropsychologist. And while there seems to be a lot there, we ask for a lot. We don't usually use this much. It's just that if you're a very complicated case and we need to see you back for support, these having all these codes makes it easier. The ICD code is the medical code that we're using to diagnose you. And so generally speaking, medical codes like Parkinson's disease will be paid at a much more will be authorized at a higher rate than a mental health code. So we code for Parkinson's, we code for memory loss. We don't code for depression or anxiety. Most commercial insurances still are not very good at knowing that that's something that actually has a medical use. And um, if you need a neuropsychologist, then this link will direct you to a web page that will help you find a neuropsychologist in your area. Okay, so hopefully this is actually helpful, like can-do information for you. And the reason for that is because we now know that, and this, all of us in this field are recognizing this stat, and it is freaking us out. If you look at the number of people who had Parkinson's in the 90s versus the number of people that were diagnosed with Parkinson's in 21, and you correct that for population growth, we are at 274% higher rates than we should be just based on population growth alone. Okay, so obviously there's more people, there's going to be more Parkinson's, but if you control for that, we are still too high. A little bit of that is due to the fact that we live longer now. A fair amount, believe it or not, is due to the fact that our smoking rates have declined. And nicotine is neuroprotective against Parkinson's. Do not go out and start smoking. Because while we can see that nicotine, not tobacco, not cigarette smoke, that nicotine is probably neuroprotective against Parkinson's, it is not protective against cardiovascular disease, heart disease, diabetes, cancer, and all of those outweigh the improved benefit that we get from it. So don't do that. That's not going to get us anywhere. But our big problem right now is that in the industrialized world, more and more of us are exposed to pesticides, solvents, and heavy metals. It starts in childhood because many of these substances have leached into our water systems. If you have an occupation that used these types of things, you're at a higher risk. And that means that you then have to be extra vigilant about doing all the things that we know can help prevent or delay the onset of Parkinson's. So when we look at that, these are some of the chemicals that are now being shown. You may have heard that Michael Oken and Dr. Roy, first name, crazy. It's right there on the tip of my tongue. Not
Ray
going to come out.
Dorsey.
There we go. See that? Younger. It just pops out. So good. They've come out with a new book, second edition of their Parkinson's plan, very clearly outlining the risk of very common, unfortunately, very prevalent industrial toxins that are were just approved again by our current FDA and CDC. These are the ones that we know are associated with increased risk for Parkinsonism. And these are the ones that we're trying with everything in our bodies to try to reduce access to or exposure to. But we're still not there. So some of the modifiable factors that we can hit hard right now. Two studies have come out, one to 2011, one 2021, so 10 years apart, that have shown the benefit to Parkinson's for delaying onset by changing the types of foods you eat. In green are the types of foods that are part of the MIND diet. That's a Mediterranean dietary approach to stop hypertension, intervention for neurodegenerative delay diet. So really long, but it's just MIND. This is a type of dietary approach that is now being shown to improve brain health, cognitive health in folks at risk for Alzheimer's, in folks at risk for Parkinson's, and frankly, in folks at risk for all-cause neurodegeneration. It seems like the green leafy vegetable is probably one of the biggest components to focus on. These are really high in antioxidants that help scoop up all the toxins that we're exposed to and get them out of the brain system. So take a picture of this. These are the types of foods you're going for. It's actually a really easy thing to do. Instead of processed Oreos, you grab berries and dark chocolate. You did it. Instead of potato chips, you grab a handful of nuts. You've done it. So simple changes can make a difference. And what we find is there's a dose response. So the more you eat in this area, the longer you delay your Parkinson's. So the study that came out by Metcalf showed that people with higher adherence to this type of food selection can actually delay their onset almost 10 years to 20 years. That buys a lot of life without Parkinson's. And it's never too late to start. So even if you're diagnosed now with Parkinson's, changing the type of foods you eat prevent rapid decline. So it's never too late, and it's not really that hard. Some other areas that we show, and this is a silly thing that I developed that I give to all my patients that help. Sensory loss, we know, is a major contributor to cognitive decline. So if you have hearing loss, if you have vision loss, get over the ego. I don't like wearing glasses either. But the problem is that when you have sensory loss, that means that downstream in your brain that should be obtaining these neural signals isn't. And what we know from the body is if downstream is not getting input, it begins to atrophy away. We can see it in muscle mass. We can see it in brain. So this is a very simple way of preventing cognitive decline, of reducing your risk. Blueberries reflects the MIND diet. So thinking about avoiding highly processed foods and moving more towards a plant-based diet. We want lean proteins as much as possible. So sub out occasionally salmon for your nice steak. Don't deprive yourself. If you want a steak once in a while, have a steak once in a while, but don't make that be your daily protein. Bicycles refers to exercise. So physical exercise is shown to delay cognitive impairment. Physical exercise has been shown in people currently diagnosed with Parkinson's and those who are prodromal to reduce the amount of physical disability. We can see it just in the course of 15 minutes. So in 15 minutes of exercise, the brain of someone with Parkinson's has an increased dose of dopamine available to them. You move faster, you move with more ease. We don't want you to become socially isolated. So buddies is important. social isolation is associated with an increased risk, almost 5% higher risk of developing dementia. If you don't use it, you lose it. And that goes along with the books too. Be a lifetime learner. If you couldn't, if you don't care about reading, no problem. Find something else, but find some purpose with retirement. Sitting down and watching TV 24/7 is not it. Sitting down and watching cable news is not it. And the reason for that is it just causes depression and anxiety. So get out, find something, walk dogs, volunteer at a library, help little kids learn how to read. Doesn't matter what you do, but do that. Bed is important. We know that a prodromal symptom of Parkinson's is sleep disruption. It's something to talk to your primary care doctor about, and if necessary, a sleep consult for this. Um, Much of your sleep is dictated by your sleep hygiene, and that's very easy to Google. There's thousands of different pages that will explain what sleep hygiene is. Um, in very simple terms, go to bed at the same time. Sorry, I'm very close to a road. Go to bed at the same time, wake up at the same time. Make sure your bedroom is cool. Don't watch TV and don't play games before bed because that's what your brain is expecting when it wakes up in the middle of the night. All of us wake up in the middle of the night. Give yourself the best option for falling right back to sleep. Avoid benzodiazepines. Those are Xanax, Ativan, Valium. Depending on what generation you're from, they were readily prescribed. Those are unfortunately really dangerous drugs for your brain, especially as we get older. They cause an increased risk of confusion. They cause an increased risk for falls. If you're currently taking a benzodiazepine for something other than REM behavior disorder, talk to your primary care doctor about that. REM behavior disorder, truthfully, the best therapy for it is a specific kind of benzodiazepine. It's better to be on that one than not when it comes to REM behavior disorder. Booze, watch what you're drinking, right? A lot of us at COVID got into a habit of, 2 glasses of wine a night or 3 glasses of wine a night. Alcohol is inherently toxic to the brain. It just is. And unfortunately, it's toxic to the brain's balance system. It's toxic to the brain's memory system. So you're thinking about how am I going to reduce my intake? It's better not to be drinking every day. If you're going to drink, it's better not to have more than 1 or 2 at a sitting, depending on your size. As we get older, our livers get worse at processing it. The toxic effects of alcohol go up. Blood reflects cardiovascular health. Understand that whatever is bad for your heart is also bad for your brain. And the two of them are so interconnected that a lot of times it's difficult for us to know where brain health and where cardiovascular health separate. BMI is important, obviously, because the heavier you are, the more sedentary you are, and the higher your risk for diabetes. And there's a whole line of research that will tell us that diabetes or Alzheimer's disease is essentially type 3 diabetes. Glucose control is so important for for the cellular integrity that when you have diabetes, you're at 7 to 12 times higher risk for developing dementia. So we want to prevent that before it even starts. And that means your diet and your physical activity. Now, you can take a screenshot of these. This is from the Lancet. The Lancet puts out has a commission for reducing risk of dementia. These are all the things we've just talked about. If a person comes after these behavioral changes like a warrior, like really thinks about not how good do I look in this bikini, but how long am I going to live? And this is why I'm out exercising. You should continue to look good in your bikini anyway, but still, this is because if you do these things, we can reduce the rates of dementia by 30 to 50%. This is not just, for fun. This is not just a wellness kick. This is about living well in your 70s, your 80s, and now many of my patients' 90s. But you have to make these changes when you're in your 40s, 50s, and 60s, That's not to say 70s is too late. The more you do now, the better. But we don't want you waiting until you're 85 to decide you're going to put away the Oreos and pick up a few blueberries. By then, we really are starting to see it difficult for a person to recover back some of that physical health. Okay, hopefully that gives us a starting point.
It sure does. And we have some good questions lined up, and I invite everyone to add what they've been chewing on. Um, so one question people, this is an easy one, is could we get a copy of those slides so people can
Oh, of
those
course. Yeah,
okay.
I'll send
Okay,
those out to you just as soon as we're done.
cool. Okay, so we had two recommendations for your BBB, better brain behavior: banjo to learn a new musical instrument,
Yep.
and bonk to avoid head injury.
Yes, I love it. I love that. What I will say is this about the head injuries. We do know that repeat concussion um, raises your risk for Parkinson's disease. Um, think Muhammad Ali, right? That came from there. Think about think about the sports you you do, right? So I'm probably not going to recommend boxing or bull riding as the prime sport. Um, those are repeat concussions. They're repeat concussions every day, all the time. The jury, I will be honest, is still a little bit out for how much concussion definitely increases risk for things like anatomical CTE. I'm an NFL consultant. I do the some of the testing for patients. I've tested probably 200 NFL players at this point. I think when the research comes out, we aren't seeing this epidemic of dementia the way we thought we would see it. So I'm gonna say that no head injury is better than a bunch of them. I'm not sure how much bang we'll get for our buck. Don't like if you haven't picked up boxing, let's not start. Like MMA, if you're not doing that, there's plenty of martial arts that you can do without getting like your bell rung every single day. And certainly severe head injuries, that's different than concussion. Severe head injuries, that is a no-brainer. We know for a fact that many people will not recover from a moderate to severe brain injury. And if they do recover, they won't recover to their full functioning. Banjo, wholeheartedly, because that's going to be part of your lifetime learning. And banjo, all musical instruments like Tai Chi um and like rock steady boxing or something like that, combine timing with knowledge, timing with movement. Anything you can do that's gonna integrate your cognition with your movement, that's improving things.
Hmm, very good. One question about specific question about diet. Any knowledge of cooked leafy greens versus raw leafy greens?
So it turns out that some leafy greens are gross. But but still eat them. You have to have your leafy greens with oil. They don't digest as well. They don't we can't get the nutrients from them as well if we don't have them with some kind of oil. And so when you're having your kale salad, oh, I'm not a fan of I don't like kale, but I eat it anyway. Put the olive oil on it. Think about how you could throw it in the air fryer and make little kale chips. If you love kale, awesome. But make sure you're having it with olive oil, and it doesn't seem to matter as much whether they're steamed or whether they're raw, as long as they're not under like a heavy bad fat. Like, unfortunately, mayos and ranch dressing and those types of things aren't giving you the kind of nutritional benefit as something like olive oil, avocado oil. Those oils are higher. Yes, benefit kale smoothie, go for it because it's also going to have blueberries. It's going to have your berries in it too. And nutritionists will tell you, we were at I think one of the Davis Finney talks. They had a nutritionist and they were being asked, well, how come supplements don't seem to work as well as the raw food or the natural food? And it's because it probably is a combination of all these foods together that give us the true nutritional benefit. So just taking a pill doesn't ever seem to work as well as making this part of your diet. Like if you think about the way a Mediterranean diet works, it's usually going to be garlic, tomato, olive oil, plus, some kind of lean protein, and all of those things together is the benefit.
Okay. And we do have in our audience some people who either have REM sleep behavior disorder or essential tremor, both of which often get benzos prescribed for them. Is that something people should bring up with their doctor that they are concerned? I mean, how would you, if there's someone who has a prescription for a benzo from a doctor, how would you recommend they proceed?
I would talk to I would talk to either the neurologist or the primary care doctor and ask them if they can recommend a trial of high dose melatonin, a trial of um, a beta blocker that might help at least reduce the dosage of the benzo that they're taking for those conditions. Clonazepam is typically if we end up with REM behavior disorder, unfortunately, sometimes that's the only drug that truly prevents it if it's severe. And we've had folks badly injured because of REM behavior disorder, and without sleep, cognition is worse. So all of these are going to be balancing acts. Parkinson's is a disease of balance. Sometimes we can't get rid of all the risk. We just are trying to highlight the benefit as much as possible.
Okay. And there was someone in the chat who said, who has RBD and said that high dose melatonin is effective for him. So
Mm-hmm.
that's
Mm-hmm.
good. Um, okay. So, oh, I love all the comments about people getting in their greens.
Yes,
Um,
yes, you can figure out ways to do it.
yes.
And honestly, the colored greens with bacon fat, man, that smell sounds really, really good right now. Maybe not as much bacon fat, but
Just get it down or
yeah.
yes. Okay, so there's a question. I have a parent who we think has dementia. So I've been following the news that about half of dementia is preventable. Is that true for people who already have Parkinson's? Do I need to worry about getting dementia on top of getting Parkinson's? And is it preventable?
Um, so Parkinson's by itself is a risk factor for dementia. Um, most people with Parkinson's, if they live long enough, will develop cognitive problems that are severe enough that they impact their day-to-day functioning. That's just the diagnosis of dementia. Dementia, is that's all that means. So if a person has dementia, they have memory problems or they have executive dysfunction that is severe enough that they need help with medication management. Maybe it's not safe for them to drive. Maybe they need help with their financial management. But there's a lot of different diseases that cause dementia. Over 65, the most common cause of dementia is Alzheimer's disease. But we do know that Parkinson's also causes dementia. So if a person already has dementia, um, your aim is to slow the progression. We now know that Alzheimer's disease is a chronic disease over 20 years, 15, 20 years. It's not like, oh, I have been diagnosed with dementia and in a year I won't be able to do anything. No, it's more likely 5, 10, you might die of some other cause before Alzheimer's disease actually disables you to that extent. Um, but we want to decrease the slope. We want to make it slower. And so to do that, we're looking at the diet, we're looking at how much physical exercise a person is getting, how much social interaction a person is getting. whether their cardiovascular risks are well cared for. If a person has diabetes with dementia and they're forgetting to take their medications, that is increasing the rate at which the dementia is affecting them. So we're trying to think about how do we reduce the rate by doing all these behavioral changes. If a person does not have dementia, but is simply at higher risk, maybe they have a couple family members who have developed Alzheimer's, or um, they are starting to feel more forgetful in their 50s. That's when that person attacks this like a warrior. That's when we start to see this ability to prevent or maybe delay dementia by 30 to 50%. And the same happens with Parkinson's. If you're in the prodromal phase, if you're starting to have REM behavior disorder, or you've lost your sense of smell, or you've developed anxiety out of nowhere, that's just really significant. Um, we don't want a person to basically to diagnose themselves into Parkinson's, but we also want that person to be aware that you really want to now change any behaviors that are going to increase your risk and try to go after it in a harder way.
Mhm. And even if it doesn't end up becoming Parkinson's, all of these behavioral changes are good for our bodies and our brains in so many other ways.
Exactly. All you've done, if it doesn't end up being Parkinson's, is reduce your cardiovascular risk so that you have a long, healthy life.
Mhm. So speaking of attacking it like a warrior, I love that visual. So someone in the chat said they try to recite state names or capitals during exercise to add an element of neuroplasticity.
Yep.
Could you talk about why that would even help and about neuroplasticity?
Sure. So neuroplasticity is um, is our brain's ability to rebuild circuits that may have been damaged by, let's say, hypertension or diabetes or other medical conditions. So let's say a person had a small stroke. The ability um, that was driven by that brain area may be gone. Like they might have lost the ability to speak because of that stroke. But with a lot of practice, speech therapy, repetition, their brain has the capabilities of building new routes or a new freeway system, as I like to say, to go around the damaged area. And so the skill may not be exactly the same as what uh, as what they had before, but it can be rehabilitated. And that's what neuroplasticity is. Neuroplasticity is our brain's ability to build a new road when the bridge was blown out of the previous one. But it takes a lot of practice, and the types of things like reciting the state capitals while exercising, those help. The more you learn, the more your brain sprouts these new connections. That's what neuroplasticity is.
Wonderful. Which is why that the rock steady boxing or the banjo, where it's coordination and timing and learning, that sounds like a good way to rebuild those roads or
Yes,
build new roads.
exactly.
And there's a question related to that. Are doing board puzzles good for the brain? And I'll add in, someone asked about lumosity.
Mhm.
Maybe I don't know what that is, but maybe you do.
So Luminosity is an online um, brain game platform. And so historically, we have said that none of those seem to generalize out. So you learn how to play the game really well, but it doesn't help you in your day-to-day functioning. I think we were wrong. And the reason I think we were wrong is so there was a study, we were actually involved with that at UCSD. It was 20 years ago using a platform called Brain HQ. And part of that platform included brain games that made you think really fast. Like they would show you a scene, give you 30 seconds or less to look at that scene and then test your memory for it. And um and we said, oh, well, you get better at doing that particular test, but it doesn't show any improvement in our outside neuropsych tests. So, keep doing it. It might be okay, but I probably wouldn't pay for it. I still probably wouldn't pay for it because there's a lot of free versions of it out there. But what we learned 20 years later is that a group of those folks continued to do it for 20 years. And their rates of dementia, now that they're in their 70s, are statistically lower than the people who decided to stop. And what that tells us is that lifetime learning, lifetime challenge for your brain is promoting this brain plasticity. So the idea is that if you have a lot of these highway systems connecting different areas of your brain, you just have a lot more brain to lose if part gets damaged. That's the whole idea of what we call cognitive reserve. So the reason that your educational history is neuroprotective is that that is a proxy for how much you have exposed yourself to over time. How much travel, how much social interaction, how much deep learning, how many languages. Someone said, is learning a new language good for neuroplasticity? Yes. We now know that people who are multilingual that is in itself, or bilingual, multilingual, is neuroprotective. For every word that someone who is bilingual has, they have another word and a whole nother network for that word that's grown brain. Unfortunately, I have one word. I lose that part of my brain, I'm out of luck. So learning, 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 important.
Mhm. There were two questions about any supplements that you might recommend for cognitive health, and then a specific question on fish oil.
Um, so the supplements is tough. To date, the only supplement that has shown to truly be neuroprotective is um, is a simple multivitamin. Um, and largely it's because that industry has not been as rigorously tested as, pharmaceuticals. Um, there is evidence that people who are low in their B vitamins or their D vitamin have an increased risk for cognitive decline. So certainly, primary care doctors can run lab tests to see if you're low. There isn't as much evidence that supplementing a normal level will improve your thinking. And in fact, most most of these supplements are going to be water soluble, meaning that once your body has reached the level it needs, you'll just have very expensive urine. Unfortunately, some of them are fat soluble, and we've had folks come in toxic on vitamin E, toxic on some of these other vitamins, um, and that can cause its own problem. So vitamin E toxicity can cause cardiovascular problem. Vitamin B, I think it's 12, toxicity can start to cause neuropathy. So you want to be careful about the idea that a lot is better. Um, Once you're at a normal level, you're probably good. And I still recommend try to get your supplements through your food. Um, Now that said, fish oil we know is helpful. If you can't stand salmon, it's probably not terrible to have a fish oil capsule instead. Um, there's starting to be more and more tests done on precursor peptide proteins that are that are the precursors for things like dopamine, the precursors for things like serotonin. We'll see. It's kind of an exciting time. There's a new push towards biomarker analysis so that people, it's good or bad. I think it's ultimately going to be good, but it's very anxiety provoking if you do it. So there are now these biomarker studies that can tell us if you're at higher risk for developing any of these, well, Alzheimer's and Parkinson's and a couple other neurodegenerative conditions. Um, so knowing that, what are you going to do with that information? Are you going to sit at home and freak out every time you forget a word, which by the way happens to me about 100 times a day? Um, or are you going to actually use that information to make behavioral changes? I think it depends on your personality.
Okay, a couple specific questions about medications. Do you know anything about whether low dose statins affect either Parkinson's or cognition?
There is low dose, probably not. There are a few people who have a side effect from statins that causes memory change. It's not permanent. Um, and I've only seen one of these people in my entire career, and it was very clear. They were fine. They started a statin, they had measurable memory loss. They went off the statin, they were fine again. That is less common than a person who has cardiovascular disease, should be on a statin, doesn't go on a statin, and ends up having a stroke or a heart attack. So I would say for those people who have a higher cardiovascular risk, um, that the benefit of a statin probably outweighs the risk of memory decline. That said, if you're a person who has a lot of cramping on a statin, definitely talk to your prescriber about that. They can change the type, and there are new medications that work like a statin that don't cause that same cramping.
Okay. If you're already using time-release melatonin but not getting an effect, is trazodone or Advil PM better?
Trazodone by 1,000 trillion times. And the reason for that is that Tylenol PM, any of the PMs, the PM part of it is a medication called diphenhydramine, which is the active ingredient in Benadryl. Diphenhydramine has a very, very high anticholinergic property. And we know that over time, the more anticholinergic drugs you use, the higher risk you have for developing dementia. And even if you don't develop dementia, you have a much higher risk of developing confusion and balance problems if you're using diphenhydramine or those types of drugs. There's I'm looking it up right now. So as you see me looking, it's because I'm trying to remember what the website is. Um, there is a calculator. There it is. It's free. Um, it's called I'm gonna put it in the chat too. Hold on, where did I go? Just give me 1 second. Okay, I'm putting it in the chat. Um, it's called the anticholinergic burden calculator. Many drugs that we don't even recognize as having a brain effect have an anticholinergic property. So, drugs that you might be taking for urinary incontinence, for your heart, for your digestion, certainly for your mood, can have an anticholinergic property. The more of these drugs you've taken in your lifetime, the higher your risk. Now, 100%, there are some people who have to be on these drugs, right? Everything about our world is a risk benefit balance. But if you're on those drugs, you want to ask your providers, is there something else that I might be able to take that would have less of this burden? I'm at risk for whatever, or I don't like the feel. Um, Most drugs have an alternative that will decrease that risk. Not all of them. And if you're one of those people that can't switch, then you just know you're gonna get benefit from some other way. But check out that calculator. I think it's helpful.
That's a great practical tip, one of many that you've had in your presentation. Um, okay, there's a question about testing your home for radon gas, and maybe I'll expand that. Do you know anything about, some of those toxins that you mentioned that are being more linked? Is there anything proactive we could do to avoid those?
Yes, so there is a test for radon gas. It's pretty cheap. You can buy it online. Um, the and if it did happen that your house does have radon gas, the Oak and Dorsey book talks about this. There's ways to vent it so you can reduce that risk. Um, I think one of the most important proactive things we can do is wash our fruits and vegetables well. If you can afford organic foods, obviously that can help reduce your risk of pesticide. Do not think for a second that organic foods removes the risk of pesticide. It's in the water, it's on the foods next to the foods. Um, it's in our systems already. Those forever chemicals, those are real. If you can afford to move farther away from a dry cleaner, that's something to consider. Um, Dry cleaning chemicals are known to be related to Parkinson's. But washing your food makes a big difference. Like I'm one of those people that historically um, would grab an apple and wash it and wipe it on my shirt, and that was clean, and then I would eat it. And then after this stuff started coming out, I'm like, ugh. First of all, that's gross. Why would I eat it like that? And then second of all, it doesn't take that much longer to run it underwater. So wash your vegetables. That's probably one of the biggest ways. If you're in an industry that uses these chemicals, talk to your employer about how to reduce your risk of exposure. We have to have a job, and so it's not, oh, just avoid these heavy chemicals. Well, if you're a diesel mechanic, how do you do that? You can't. So think about how do you just reduce your risk.
Wonderful. Well, to close out our time today, do you have, I don't know, maybe like a couple overarching takeaways that all of us listening can, pencil into our lives and start to prioritize making a change?
Well, I think what I would say is it's hard to get started. And if you have never loved exercise, and if you have always preferred junk food over, or less nutritious food, we'll call it, over like the mind diet, I would say just start small. Like you don't have to go and train for a marathon, but if you can maybe walk 5 minutes a day, and then maybe 2 weeks later walk 10 minutes a day, and then maybe 2 weeks later walk 15 minutes a day, that's getting started. That's just moving. And it doesn't matter what you do. If you're moving your body, that's important. Same with the food choices you're making. If you have to have a sweet, go to dark chocolate and a handful of blueberries. You've just made a difference in your brain. And start small, and then reward yourself that you did that. No one is going to make a ginormous change overnight. Incremental steps matter.
Absolutely. And Kelly put a link in the chat before, and maybe you can put it again, but having others going through this with you, talking to a support group, talking to a friend, having a buddy can help with lifestyle change. And actually, at PMD Alliance, we support a prodromal support group. So even if you don't have a Parkinson's diagnosis, but you're at risk or you just want to be proactive and take care of your brain health, probably we found that, there weren't any out there. And that's not, you don't need to go to a Parkinson's support group. That's too early. But to be with those who maybe have sleep issues or losing sense of smell, a family member, we created a space for you. So have the link is in the chat for those who want to join that support group. And for those who already have a Parkinson's diagnosis, there are you are lucky. There are tons of support groups, and we have lots of tools on our website to be able to find one in person or online. And we know a lot of support group leaders who are always looking for more members to join their groups. So I love that advice. Start small, just do something little. And thank you, Dr. Hamilton, for everything that you shared. There were practical tips all the way from, what codes to ask your physician for, anticholinergic calculator, and I love your BBB list. So thank you for your work and for sharing such good advice with us today.
You're welcome. It was really a pleasure to be here. You guys have a great day.
Bye, everyone.